change in regulation for harm reduction programs in West Virginia. The change happened this legislative session that ended in April. So we're going to look at the new legal requirements for the harm reduction programs in the state. And we are going to reflect on potential impacts on us and the patients that we care for as stakeholders in caring for the population that accesses harm reduction programs. This bill that passed this year was not new, although I will say it's better than the derivations from the previous legislative session. Last year in the 2020 legislative session, there was a bill introduced by Senator Tarr, the gentleman on the left from Putnam County, who's been concerned about harm reduction programs, specifically the syringe exchange portion of harm reduction programs. And that bill would have outlawed them completely. So no syringe exchanges at all. The gentleman on the right in this picture is Senator Mike Maroney, who happens to chair the Senate Health Committee. And that bill in 2020, he did not place on the agenda. So it died in committee because he was concerned about the extent of going that far with making syringe service exchange illegal. So what we got this year was a bill that passed, which was Senate Bill 344, that kind of tried to find a hybrid between community complaints and what the science says about syringe services programs. So generally speaking, I'm sure you all know this, but the goals of harm reduction programs are to meet people where they are and help guide them into treatment through developing trusting relationships, and in the interim, minimize harm to them as much as possible in regard to infectious disease transmission, unwanted pregnancies, being a link to care for vaccinations, and preventing overdose deaths. The CDC has some specific recommendations on syringe services programs. It's available to anyone. There's 3 guiding concepts that the best practices are to provide access to sterile needles and syringes, to facilitate safe disposal of used syringes, and to provide referrals to treatment when patients or clients, however they're referred, are ready. The data that the CDC shares includes that syringe services programs are associated with an estimated 50% reduction in HIV and hepatitis C. And when combined with medication to treat opiate use disorder, like we all do, the HCV and HIV transmission is reduced by over 2/3. That new users of harm reduction programs are 5 times more likely to enter drug treatment and 3 times more likely to stop using drugs than those who don't access the programs, the harm reduction programs, and that first responders and the public are also protected because syringe services programs provide safe needle disposal and reduce the presence of discarded needles in the community. They've also done some studies in Baltimore and New York City that show that there's no change in occurrence of crime in communities that have harm reduction programs versus those that don't. And the best practice recommendation from the CDC is a needs-based approach. And what that means is that persons who inject drugs get a new clean syringe and needle for every injection, every individual time that person injects. So they provide supplies to dispense to both the people that access the program and also recommend proxy distribution, meaning someone that comes to a syringe services program can get equipment and supplies for someone that might not have access to that program. There's no restriction or mandate to return used syringes in their needs-based approach recommended by the CDC. And they state that the most restrictive policies are the one-to-one exchanges. And they've found that those with more restrictive policies are associated with higher risk behavior and higher rates of bloodborne infections. The need-based approach also reduces needle litter in the communities by providing sharps containers and community cleanups and drop boxes. And of course, they provide referrals to treatment when participants are ready. The CDC also recommends that when appropriate, they offer other services like education on high-risk behaviors, condom distribution, screening for infectious disease, naloxone distribution, referral to treatment for infectious disease, and prevention, including vaccinations. And just before we get to what the state of West Virginia has done prior to this bill passing and what we will intend to do after this bill is implemented, I want to just reflect on the access to syringes. Really, if you have an internet and you have a credit card and an address, to get 100 syringes with needles, it's only about $17 on Amazon. So they are accessible for people that aren't, that have the capacity to have it shipped to a home address and have money to pay for it. But oftentimes clients that access harm reduction programs are the very sickest, and they don't have those luxuries. So what the state of West Virginia had done since 2018, before this bill passed, was had a program, because there has been, and I won't get into the history and the policy debates that happened in certain areas of the state. I'm sure that some of you on the call today are familiar with some pockets of debate in different areas of the state. But in 2018, DHHR started a certification program for harm reduction programs. It was voluntary, but it had some guidelines and reporting requirements to be certified. And we'll see in a few minutes that most of the site-specific programs are certified currently in the state of West Virginia. And I'm not going to go over the full guideline. There's a link to that if you want to read the full guiding document for certification. But the concepts that are outlined in the certification guidelines are that you have community support prior to and throughout implementation of harm reduction programs, that you have planned a detailed community syringe retrieval, you dispense in person versus by proxy. Remember, the CDC says that the best programs allow proxy distribution, but the certification doesn't require that. It just recommends in-person only distribution. It's not required. There are mechanisms to get participants to treatment when they're ready. There's routine program and process evaluation for quality improvement, and there's consistent messaging on harm reduction and relationship developing. So those are the concepts that DHHR had put in place in 2018 if these programs wanted to become certified. They had quarterly reporting requirements, including the number of visits by participants, the number tested for HIV and viral hepatitis, the number of participants immunized for Hep B, those testing positive for HIV and Hep B and Hep C, and then the number of syringes dispensed and returned. Those were required reporting requirements. They could also optionally report hepatitis A vaccination rates and number of participants enrolled in treatment. And you can find this online. Since 2018, they have them archived. I just wanted to share this because it's really striking the difference that COVID had on access and harm reduction. These are for exactly the same quarter for different years, pre-COVID 2019, and then, heart of COVID 2020. And they've kind of used strategic communication methods here because they put the best number, up in the right, but they're completely different metrics. So the red circles correspond with each other, the purple correspond with each other, but you can see in 2019, the third quarter, they had distributed over 10,000 educational materials to participants. And in 2020, same quarter, less than 4,500. Similarly, in 2019, they had referred 375 participants. These, again, are the certified programs in West Virginia. And in 2020, during COVID, only 133 for that same quarter. So we can clearly see, and as we know, COVID had a really big impact in the state on a lot of things, including overdose deaths, sadly. So about 2,000 less people in the third quarter of 2020 accessed harm reduction programs. About a quarter of the people for the same quarter over both years got tested for HIV, and about a third were referred to treatment between the same quarters in the 2 years. This is I'm not exactly sure if this is absolutely up to date, but these are this again was found on DHHR's website. These are site-specific programs. There are 16 site-specific programs, at least according to DHHR's data. Back in 2020, there were actually 20 site-specifics and 3 mobile. So I do know like Harrison County's harm reduction program closed, and I'm not sure what other ones have closed in between that time and now. But as you see, 14 of the 16 are certified, maybe 15, because one, it didn't designate one way or the other if they were certified. There was only one explicitly non-certified program with DHHR. So they are participating, they are giving reporting data, they are following certification guidelines that are more stringent than what CDC best practices suggest at baseline before this new bill even passed. So let's look at the new requirements. I'm not going to read the whole bill to you, but just what is new with this new law, Senate Bill 344 that passed. All harm reduction programs will have to be licensed. Not, the certification was voluntary. Most of them were voluntarily certified, but now they will have to have an annual license. And again, annual, so renewed annually. There will be penalties for non-compliance ranging from $500 to $10,000, dependent on what the non-compliance is. And the two bold ones are the ones that most harm reduction programs are concerned about. One requires elected local leaders' approval to continue the program. And if you live in a place like Monongalia County, that's Mon County Commission, Star City Council, Weston City Council, and Morgantown City Council. So they have to get all four of those elected leaders' approval to continue the program in Morgantown. And then if they also serve like Preston County and maybe Marion County, and maybe someone from Health Right can tell us that at the end, but so they would have to get the municipality's approval, the elected, and initially the bill said the sheriff, and it had to be unanimous, every member on the county commission, city council, every single one, but now it's just a majority. So that was a little bit of an improvement. It also requires an identification for a West Virginia address for any participants, which we know that can be problematic. They have not defined what West Virginia identification is yet. So during debate, they said it doesn't have to be a photo ID, but we don't know for sure yet because the emergency rules aren't written. And then it requires versus recommends, which the certification recommended. It now requires specific wraparound services for those programs that dispense syringes, and it requires syringes to be uniquely marked. So if they're found in the community, they can be tied back to a specific program. The required services, these wraparound services that are now required, and the program themselves can provide them, or they can have a referral arrangement with another provider of these services, but they have to test for HIV, viral hepatitis, and sexually transmitted infections. They have to provide vaccinations, birth control, behavioral health services, overdose prevention, supplies, and education, collect syringes and have a sharps disposal plan. They have to provide education related to disease transmission or reducing disease transmission, refer patients to substance use treatment programs, and refer them to like primary care for medical condition treatment. They also have to, the services at syringe exchange programs have to be provided at every visit by a qualified licensed healthcare provider. The bill does not have a definition for qualified licensed healthcare provider. So I presume that's going to be in the emergency rule, but I'm not sure what exactly that means right now. Minors cannot be participants. There is a goal of one-to-one distribution and return, but not a mandate. They can weigh the return syringes as long as they're returned in a see-through container, and they can no longer do proxy. And I mentioned the West Virginia ID requirement. And then they have to have a procedure for the public to report any litter they see in the community, and an endeavor to clean all community syringe dispense or all community syringe litter, and then programmatic guidelines on different things like disposal plan training, QI, and community relations. What their reporting requirements now will be that they have to annually report the number of people served, the types of syringes dispensed, collected, and disposed of. A new one is the number of syringe stick injuries to non-participants of the program, so and just anybody in the community, the number actually entering treatment, and then the total and types of referrals made of that big list of required services. The implementation for this will be July 9th, so we're not far away, a little over a month when this will be effective. Emergency rules have to be submitted by the 1st of July. I checked yesterday, I did not see them. You could, if you're interested in looking at the rules when they come out, you can monitor the Secretary of State site, and there's a couple links if you're interested in that. And there's also a link for the actual final version of the bill. So what does this mean for us as stakeholders that care for this community? A few things. If you have a harm reduction program in your community now, it might not be a bad idea to network with them and perhaps offer part of those services if you provide them as part of their plan that they'll have to submit for their licensure, things like behavioral health services, for example. Or vaccines, or screenings, whatever your program might do. Perhaps if you feel it's warranted and appropriate, assist with community engagement and support strategies, including testifying or providing information to local elected leaders and municipalities that have to now approve these. I reached out to Laura Jones, who directs as the executive director of Milan Pushkar Health Right. That's where our harm reduction program in our area is. And her biggest concerns were, exactly what I heard during the debate during the session. They're very concerned about having to convince multiple municipalities to improve their continuation of providing services. They haven't figured out exactly how to craft syringe unique to their program and what impact on costs that's going to have. Very concerned about the West Virginia identification requirement, including the perhaps losing participants to follow up because they might not have a West Virginia ID. And then obviously becoming the next Scott County, Indiana, where infectious disease, including HIV, skyrockets. One thing, other programs, I was really shocked by these numbers, frankly. This is from the SAMHSA's National Survey of Substance Abuse Treatment Services. Every year they contact a sample of service providers and see just a plethora of questions in the survey, but some of them, what kind of testing are they doing in their treatment facilities? And I was kind of surprised how low these numbers were. In West Virginia in 2019, which was the most recent survey, of all of the treatment facilities, only 43 of the 116 were testing for hepatitis B, 45 were testing for hepatitis C, and 38 were doing HIV testing. So there's room for improvement there. And considering that there might be some decreased utilization of harm reduction programs, it might be something that we want to take heightened awareness of. Make sure that we're screening intakes and consider data tracking that, either the infectious disease element or any of the elements that your local community might be concerned with as far as metrics. I think infectious disease is a very important one. So you may want to consider, if you have the resources and the time, to baseline your intakes prevalence rates of that viral hepatitis and HIV, if you do collect them, and then track them perhaps monthly. I know DHHR is going to be tracking, because that was a big concern that the people that were concerned about this bill testified about, like becoming another a hotspot, which we actually do have a couple counties already in the state that are having high HIV rates. So trending patterns, we as providers probably will be one of the first, other than labs, local labs, to see spikes. So if you trend some of these metrics and you notice a spike, contact your local health department or reach out to DHHR. But we'll see how it goes. Hopefully it will be okay. There's also, I believe, Charleston, Kanawha County, they did their own kind of version of harm reduction ordinance that I believe is a little more stringent than this. But I haven't done an analysis of that, so I couldn't tell you. Maybe some Charleston participants could. But we'll see how it goes. I will say that legislators often tweak bills, especially high-profile bills and ones of concern. So if there is data that would compel and be convincing to maybe tweak this for next legislative session in 2022, I'm sure that they would be receptive to having any data that you have noticed impacts the patients or your communities. And that's it. Any questions?
Tony, great, frustrating and great presentation. Are you aware of any other healthcare treatment programs that require elected officials' approval?
No, I am not aware of any healthcare related things that, I mean, other than like the legislature has set up office-based MAT policies. They have a moratorium on opioid treatment programs, methadone. Mm-hmm. So, and that way, policymakers at the state level, like the legislature, have that. Local elected officials certainly can make ordinances, and they frequently do. But I have never seen it defined in a statute like this.
Yeah. Okay. Thank you.
Just to clarify, we're getting rid of evidence-based medicine, replacing it with cannabis in West Virginia, right? Perfect.
Yeah, well, That is one of the quotes that, and this is not untrue, and I think we've all seen this through COVID, but one of the quotes from a physician legislator was that there's more than science to this issue, meaning that community and cultural and stakeholder constituent concerns have to be listened to too. And I totally understand that. But I mean, the people that were opposing this, and believe this derivation is much better than the original derivation of the bill. But the people that were opposing the language did continually reference, the research and the science that dictates that really, frankly, what the CDC research shows as syringe litter actually decreases with harm reduction programs in communities. So, but of course we won't know what that looks like.
Yeah. So Tony, question. So, we now have elected officials doing healthcare decision making, which, they get themselves involved in other things, and even non-evidence healthcare decision making. But as a clinician, how much can we do outside of this? Now, so this applies to harm reduction programs. As a physician, am I allowed to prescribe syringes? I think I am. Whether I do or not, it's a whole other story. And so this to me is, it's a huge problem. I mean, the data is going to show that, we don't have a hot spot in Charleston in HIV, right? That's not a hot spot. I know everybody knows I'm being sarcastic, but, we are really putting our population at risk. There's a certain population that is really, we are encouraging HIV transmission, hepatitis A, C, and healthcare costs will also go up. So I guess, as a group of, everybody here takes care of people in one way or another, what stand do we need to take, or what can we do? I guess, and again, it's not even on the politics side, it's taking care of our patients. I mean, we all take care of this population, and I'm very bothered by this. I'm sure some other people are as well.
Yeah, that's a great question that I didn't garner the nerve to ask, but that's exactly what I was thinking during this debate. Like, okay, and the statute is specific to harm, syringe services programs. If you as a physician or anybody that can prescribe chooses to do that, is that okay? I didn't want to ask the question because I wasn't sure if I wanted the answer. But I do know that this only applies to syringe service programs.
Right, because West Virginia is really good in that. We're known for lacking laws, so there's a lot of gray areas in West Virginia law. It's in taking care of our patients. I mean, what prevents me from ordering those Amazon syringes? And I don't think there's a dispensing law in West Virginia against syringes. I know there's dispensing for I can't dispense medications from my office unless I have a special license, but I don't know if that falls under that. Now, again, that's a rough around, because the truth is most of us here aren't doing the harm reduction, whether it's valuable or not. It's people that are committed to this and have been working really hard and staying within those guidelines and writing a lot of paperwork, which I just don't have the time to do. But it is, I think, as professionals, I think we need to probably, speak up more than we are. I mean, people will all of a sudden all across West Virginia, when the CDC said you don't have to wear your mask, masks came off. Now when the CDC says needle exchange is valuable, that won't be listened to, obviously.
Selective hearing.
Yes.
I like the idea of that, like if a needle exchange were to just start maybe ordering online and just ship it to somebody, because that's technically not giving that to them, right? I mean,
yeah. Oh, they could. I donate $20, and here, what's your address?
Exactly. Exactly. There's nothing that you can order it for people or something. So it's not
about.
Or
they could. Yeah, we can facilitate ordering the same way I facilitate them getting on Medicaid at the office, or I don't know. I mean, I'm just trying to, stay within the bounds, and again, as university employees, there's a whole other, but as professionals, I think we have an ethical obligation.
Human beings, for that matter, which
right.
politicians apparently aren't. So
yeah.
I remember working with the methadone program in Baltimore and the politics around that. And in general, the government felt like it was a good idea, but nobody wanted it in their backyard. And so I think that's what you're kind of working against, is the community pressure.
Yeah.
Yeah, no doubt about that. The harm reduction program in Morgantown was really the first in the state. They kept it very low key. Cabell Huntington's health department, most of them are in health departments, and Cabell Huntington's health department is touted as being the first harm reduction program in the state, but it was really my own Push Girl Health right in Morgantown. But they were just really quiet about it. They did talk to like the health, they came to the health department, presented to our board, and they talked to, you know, local law enforcement, and they really were like buying or committing to work with the community, but they weren't advertising it, because exactly what you're saying, Dr. Herscher, when everybody gets concerned about it being in their backyard, then you start hearing a lot more complaints, whether it's perceived or actual.
I know the one in Harrison County in Clarksburg, when they stopped that, it was more of the society saying no, but I actually would go there on Thursdays as a peer recovery coach and be able to talk to all those who came in, and some of them took up the advice saying, yeah, I do need help. Others would, no, I'm not ready. But I did notice, you know, they came in and got their wounds checked. They came in, and if they had other issues, they were being seen for that, because we know as addicts, those who are addicts do not go to the doctors. So it was not only that with the harm reduction, but it was actual more physical self-care that was more involved than we saw.
Did Harrison counties close?
Yes, unfortunately.
I heard, I think it was David earlier brought up the idea on the dispensing side. So as that guy, I would like to clarify or expand upon and add on to what David was saying there is, we are talking about an OTC product here. Anybody can walk into a pharmacy and get that. So perhaps to provide us, especially on this call or Zoom or whatever we're on, it's Monday. Would you provide a script for somebody to get Imodium? And I just have reservations in looking out for everyone in creating legal documents. Take it for what it is, because all it takes is one reporter, one law, whatever. So where does that leave everyone? Well, I would not recommend just sending a person, a patient, a customer just to a pharmacy blindly in my own profession. I would call ahead and have that conversation to make sure that they have it and they will give it. I've had those conversations, whether it was naloxone, syringes, you name it, lisinopril sometimes. Do you have it? Will you give it? And the answers are not always what you're going to want, but at least you'll have taken care of that along the way. Every profession has its people with their opinions, no matter what. Like Tony was saying in the beginning, that there's lots of sides to the coin. There's society. I think they were, I'm not quoting anybody of the like, well, there's more than science. I know our crew that we're here, so always know your audience, right? I'll share a story. I'll put it out there, and it's a story of judgment. So feel free to judge me. I don't know if I handled it correctly. But I remember working in a pharmacy. Somebody mentioned Baltimore. Yeah, I worked in a part of Baltimore where that's where the hair went. And a gentleman came through the drive-through of the pharmacy in one of those like H2, H3, I don't know cars, but that, a really cool like army style vehicle. This guy was so built that he could crush me with his pinky. Okay, I'm building my judgment here. And again, I don't know if this is good. But when he asked for syringes for his little grandma, and I waddled on over to the drive-through door and said something to the tune of, this is like a decade ago, folks. I'd like to have a conversation with you. Are these really for your grandma? I got a grandma too. I want to help and all that. And he's like, well, what do you, we're getting fight or flight's kicking in already. And remember that when I told you about how like he'd kill me with his pinky? The bottom line of the conversation was, what it ended up being was that asked him if, from what he was saying, it seemed like he may have been utilizing the syringes for himself, and it was for testosterone. It wasn't for things we're talking about. The problem is that he was using the wrong length of the needle. So I was able to help him out with it. And you think about where you're injecting testosterone, that's a PETA, eh? If you're doing it wrong. And again, that started out perhaps, or definitively, 2019 was when we used to say kind of judgment, right? Straight up judgment. And again, but the point is, when I was in that role, I was willing to, and not all of my colleagues in my profession are, just like in whatever profession you're in, same thing. So have those conversations ahead of time. Feel free to share any wonky stories along the way. But it is, and all of that also requires money, because they're not going to be handed out. So they're still going to be sold. And that's not always the case of what's going to be easy in many of these scenarios either. So there's also stories where this is actually a published one. It's in, I think, Drug Topics or something, where my brother-in-law's got type 1 diabetes, and he forgot his syringes one time. He went in, and he was in that stage of life where he wanted to grow a beard, and it wasn't even NHL playoffs. And the pharmacist judged him and wouldn't give it to him. So my father-in-law called the pharmacist, because turns out he's one of us too, and was like, "Hey, my kid wants to grow a beard. He actually has DM1. Can you give him some DM syringes?" And he came right back in and did that. There's countless versions of these stories. I'm just using the ones from my own family and myself, where they happen. And when you're in those moments, it's tough to make those decisions, because not everyone thinks about that ahead of time. I challenge our student pharmacies even to say, when there's a patient having an asthma attack in front of you and you're in the pharmacy, what are you going to do? So if you don't think about it now, you're not going to know what to do or quick enough. So very long version of saying, call ahead for them, or know who's in the community and who will and who won't. And that changes because people change their minds too, personally and professionally. So, and Rant.
Thank you so much. I always love your stories, Mark. They're amazing. No, this is really informative. I'm sad to hear about Harrison County. I'm originally from Harrison County. Well, after I moved from Nevada to West Virginia. And I just know it has a lot of issues, and I've seen some of my friends, or now acquaintances I don't get to speak to anymore, but go through pretty tough times. But I'm just, appreciative to what all you guys do and how you handle this. It's very challenging. And does anybody else have any comments or questions for Tony or for the rest of the group, or any more great stories? I do have a question about the disposal of needles. So does someone go around and clean or help clean them, or like, how is that done? Because I will admit, I come across them and I don't know what to do, because I feel like I'm responsible if I see a needle on the ground when I'm walking, like for instance, Decker's Creek over here in this area. And if I see one, I want to grab it, but I'm also like freaked out that I, could get something, or I don't know, I just freak out like a little bit. So I didn't know what the advice was there.
I don't know if anybody, I know some people from Health Right are on the call right now. I don't know if any work in the harm reduction program, but I mean, it's my understanding that if you call Health Right and tell them the location of where you're seeing used syringes, they'll come out and pick them up.
Awesome. Thank you. Yeah, that would help.
And a more progressive thing is, what if we knew where these sites are and we put needle disposal containers there in all bathrooms? We do, I do work with people, and, even our diabetics, we don't ask them necessarily to buy needles disposal stuff, but you can use detergent, all bottles, and they can go in there. It's almost quite one way, and so it's, disposed syringe out there is a problem. I mean, I've had patients in the hospital dig through the safety boxes to get syringes out of them. I mean, that's pretty desperate. And so, so.
Thank you. Yeah, that is desperate. I almost fell on one day. It was not a good moment.
And I think we stumbled upon like a additional patient counseling point there, a little bit less heated version. But so when you get a sharps container, typically they're grabbing them at the pharmacy or a med supply store or whatnot. I kind of learned this the hard way early in my career. So you sell the thing to them, and then they have to pay to get it shipped away and taken care of as well too. So really, in reality, what happens? It's thrown away. That's not what we're going for, but the Tide thing made me think of that. So thank you. It's those thin ice things or whatever, but I think just remembering the basics is always really important. Something like that of the, like, you really think somebody's, and people will, of course, but you're doing the right thing, but will everyone always pay for a container and then pay another 10, 20 bucks to ship the thing out? So things just to keep in mind.
Yeah, there would be really, like, Saberton area would be a nice disposable. That'd be a good idea, and somebody could clean that up. And yeah, because it would be safer and just better. So that's good to know, because I don't think they can pay to send it back. Yes, Jennifer.
I just thought of a question for Tony. Tony, I think you said the legislation kicks in on July 1st. So harm reduction programs have to demonstrate that they have a lot of things in place. But as far as the data collection, if that's annual, do they not have to report until 2022 on things like, number of tests done and number of needles dispensed? What's the reporting timeline?
I can't recall exactly the timeline. I mean, July 9th is the date of implementation, but there is a phase-in period. So again, knowing that most of these are certified already, they'll continue I believe their data reporting that they have done quarterly to date.
Quarterly, okay.
That's what they were doing
Gotcha.
with certification. Now it's going to be an annual report. But really, the devil of implementation is always in the rules, like things like definitions and what exactly reporting metrics, obviously whatever is in the bill has to be, but there are oftentimes additional reporting requirements and how you compute, the numerator and denominator of some percentage. So I will be really interested in seeing OFLAC. I presume OFLAC is going to write the rules, since they're going to do the licensing, the rules on this one.
Yeah. And I know that for our out here, our harm reduction program, they've taken it absolutely the opposite approach. And I think Mark, for keeping you out of trouble, but they're going to meet they're really shooting to meet every requirement and show them that it can be done, even though they disagree adamantly against it. But it's so important to keep it going. I do think we need to remember that our legislature meets every February or so, and so laws can be undone, and and so basically they've turned public health away from the government and turned it on to individuals and put restrictions on that public health to the level that I don't think it can be most groups won't be able to do this. I mean, it's going to take big places like Health Right, potentially out here where we've got some really dedicated people. But it really has turned, public health from public health to, individual mandate, for us to do that. So.
It's Nick from Hamlin. So something I was thinking when you guys were talking about harm reduction, does anyone know of any programs giving out BD safe clips? They're little snippers. They'll snip off the needle part and store the broken needles in a hard plastic container. Anybody hearing anything about that?
I'm familiar with that tool, but I don't know. I'm not sure if anybody is dispensing those, to be honest.
I'm not aware of that. Tony, is there any other, is it just the needle exchange part? Because harm reduction also plays a lot of other stuff, that they do hand out. They don't just hand out needles, they hand out cookers, and they hand out bleach, and they hand out, different things. Is this just address the needles, I